Welcome, and well, you can see me, I cannot see you, but I'm going to take you through dietary restriction for a possible treatment of type 2 diabetes. That's the topic for the next 30 minutes. We know that dietary or caloric restriction prevents diabetes. Approximately 20 years ago, two back-to-back studies proved that or described that when doing lifestyle intervention, obtaining a substantial reduction in body weight, you could also obtain a robust reduction in the incidence of new diabetes cases. So caloric restriction, is that for type 2 diabetes, or is that for all kind of disease? This is an old study from the Coleman group describing monkeys put on dietary restriction, and they ended up with a robust reduction in all cause-related diseases. But I'm not going to talk about monkeys or rodents today. Today, this is a human perspective. Caloric restriction, you can obtain that in various ways. You can do that either by total diet replacement, or you can manipulate with the diet that you are having, or you can do surgery. And I'm going to touch upon both of these points. The first thing I'm going to talk about is total dietary replacement in type 2 diabetes, and that's the DIRECT study. The study was performed in primary care settings in Northern England and Scotland, and as you can see, the criteria for entering the study was you had type 2 diabetes of less than 6 years of lasting less than 6 years and not receiving insulin, and you had to have a BMI between 27 and 45. At first, you were on a quite flexible, very low energy diet, ranging from 825 to 850 kilocalories a day, and that was bound for 3 to 5 months. The duration up to 5 months was if the participant wanted to do a longer, very low energy diet time. After the very low energy diet, a gradual reintroduction to regular foods was introduced over the next 2 to 8 weeks. The endpoints of the study was weight loss above 15 kilograms or diabetes remission with an HbA1c less than 48. And as you can perhaps, I don't know if you can, but see the background for the study group, the average body weight was around 100 kilograms, and the distribution between males and females were almost equal. The BMI was between 30 and 40. When doing the 1 year, the first year follow-up, almost 100% data was obtained during a meticulous work from the study group. They had data on the primary outcome, which was a weight loss less than, more than 15 kilograms, and it was obtained for almost 100% of the participants. As you can see, almost 25% of the participants achieved a weight loss more than 50 kilograms, and that equivalent a remission of diabetes of approximately 50%. So a very nice and robust remission rate for this first year. When looking at the second year, and these data was available early this year, you can see that year 2, where the people were free living, they had indeed still contact to the general practitioner, but they were primarily living at home. When they met at the general practitioner, there was a rescue plan for all of these patients. meaning that if, for example, the body weight was increased by 2 kilograms, the subjects or the people had the opportunity to either go on a modified total diet replacement, and if the body weight was above 4 kilograms, there was the possibility of receiving, for example, orlistat for body weight reduction. Very few people had needed to receive orlistat. As you can see at year 2, there was still 11% of the subjects who had maintained a weight loss above 15 kilograms, and that equivalent in the year 2 to a 35% remission rate of type 2 diabetes. So even when the people were kind of free living, there was still a very robust reduction in body weight and a sound remission rate. This slide illustrates the dose-response relationship between body weight and remission rate, meaning that if you have a body weight reduction of less than 5 kilograms, the remission rate was very small. However, if your body weight reduction was above 15 kilograms, you had a very high remission rate, almost 90% after year 1 and 80% after year 2. So this is also a reminder when doing clinical trials or doing ordinary medical work, that with increasing body weight, you have an increase in remission rate of type 2 diabetes. One important point in this direct study is that the subjects entering, they were not having insulin. So a fairly relevant question is, how does insulin treatment look like? So another group, and this study was published this year, looked in a rather similar setup on type 2 diabetes remission, total diet replacement in subjects on insulin treatment. These subjects, they had on average had type 2 diabetes for 13 years and received insulin for 4 of these years on average. The BMI was on average 37, and they were placed on a low energy diet, approximately 800 kilocalories for 12 weeks. After that, they had a reintroduction to regular foods over the next 12 weeks, and there was calculated a 600 kilocalories deficit. The control group, they all received a 600 kilocalories deficit. And the endpoints for this study was weight loss after 12 months and insulin use. As you can see, the change in body weight, the control group reduced their body weight, of course, since they had a 600 kilocalories deficit in their usual food intake. And the change in body weight for the intervention group was indeed more robust, which also is due to the low energy diet. Again, the weight losses was of course larger in the intervention group, the black bars indicating that almost 80% of the subjects had a weight loss above 5%, and almost 50% of the subjects in the intervention group had a weight loss above 10%. But it's a very relevant point to see that even in the control group receiving a deficit of 600 calories, you had a 50% reduction. You had almost 50% had a body weight reduction of more than 5%, and 20% had a body weight reduction above 10%. The HbA1c displays this, and interestingly, in the insulin, the secondary endpoint is that the insulin omitment was, of course, larger in the intervention group, with almost 1/3 of the patients not receiving insulin after 1 year. So total diet replacement is also effective in type 2 diabetes subjects receiving insulin treatment. The two studies were performed in Europe and Australia. However, does this also apply to other people? This is a recent study performed in the Middle East, in Qatar. They had the inclusion criteria was type 2 diabetes of less than 3 years of duration and a BMI above 75. Sorry, 27, of course. They were also put on a very low energy diet, approximately 800 kilocalories for 12 weeks, and then reintroduced to regular foods over the next 12 weeks. The endpoints in this study was weight loss after 12 months, diabetes remission, meaning a HbA1c less than 48, or normal glycemia, meaning a HbA1c less than 39. In relation to weight loss, the weight loss was substantial in the intervention group, with 60% having a weight loss above 5%, and then, of course, being less than 30% in the control group. And this was also the case for the larger weight losses, where the above 15% weight loss group, it was only 20% that achieved that after 1 year. It's interesting that the HbA1c was normalized in a lot of these subjects, which is also due to the short diabetes duration. As you can see, there was an average duration of diabetes of approximately 20 months. And that is also very clear when you look at the proportion of participants who received diabetes remission or even normal glycemia. 61% received diabetes remission, and 1/3 received normal glycemia in the intervention group, and only 12% received remission in the control group, and a very little number received normal glycemia in the control group. So in a different population, in a different setting, this point on total diet replacement seems to be highly effective as well. And this paper, in fact, led to a comment in Lancet, where Roy Taylor, one of the main characters behind the DIRECT study, concluded that that total diet replacement is also feasible in other populations than Caucasian population. Okay, the next point I'm going to talk about is surgery, because that is also a kind of dietary restriction. When you do bariatric surgery in Denmark, we have two options. We have gastric sleeve and we have Roux-en-Y gastric bypass. This is the first paper from the Stampede trial, initiated around 2008. This is the data from the first year of the trial. The people was included into the trial and in a way randomized to either gastric bypass, sleeve gastrectomy, or medical treatment. The endpoint was an HbA1c less than 6%, equivalent 42 millimolar per molar. And it didn't matter if the people were on received diabetes medication or not. After 1 year, the endpoint was highly significant, comparing medical treatment with the two bariatric modalities. There were no difference between the two bariatric modalities. As you can see, the change in BMI, the two sleeve gastrectomy or gastric bypass were equally effective in reducing BMI, and there was only a minor reduction in BMI in the medical treated group. And remember that the medical treatment group, the point was to reduce HbA1c. Looking at the further perspective of bariatric surgery, this is the 5-year data from the Stampede trial. And the figure here illustrates glycolated HbA1c, and this illustrates the medical therapy, indicating that during the first 6 to 12 months, the intensified strategy in relation to obtaining the primary endpoint, an HbA1c less than 6%, was very effective, almost as effective as the bariatric surgery. However, looking at the long term, looking at the 5-year data, the HbA1c levels were almost the same 5 years after in the surgery group compared to the medical treated group. However, this point equivalence of approximately 2% reduction in HbA1c, which is also quite impressive. So there was a very effective treatment in all the groups. However, looking at the medication, and this is the point down here, you can see that the medical treated group, many of these subjects had still, after 5 years, they were still receiving insulin, compared to the 2 surgical groups, the gastric bypass and the sleeve gastrectomy group, where only approximately 10% each received insulin. And again, looking at the dark blue, only a very few patients did not receive any kind of treatment in the medical treated group, and in the gastric bypass group it was almost 50%, and a fourth of the patients in the sleeve gastrectomy group did not receive any kind of medical treatment. So even though the HbA1c was in some way well performed or well obtained in the medical treated group, that was due to a heavily medication. And in the surgical groups, it was probably due to the weight loss, which is exemplified here with a very robust reduction in BMI. As you can see, the initial decline in body weight and BMI, meeting a nadir around 18 months, was sustained for up to 5 years. At this time point, interestingly, there was also a significant difference between the gastric bypass group and the sleeve gastrectomy group in favor of the gastric bypass group. But looking at the medical treated group, they still had a reduction in BMI from baseline and up to 5 years. So in this group, intensified pharmacological treatment and lifestyle intervention did in fact do so well that they did not, as we often see with people with type 2 diabetes, increase their body weight, but oppositely they reduced their body weight a little, but of course not to the same extent as in the surgical groups. When looking at, as you probably not remember, what I will recapitulate, in the setup, there was no there was a lower limit for inclusion, but that was around a BMI of 30. And when you did the division of the BMI below 35 and above 35, you can see that the medical treated group, they did similar well. So it didn't matter if your BMI was below or above 35, and the same was true for the surgical groups. So, and the surgical group was combined to 1. So the effectiveness in relation to changes in HbA1c was similar, despite your BMI start out. So it doesn't matter if you have a lower or a higher BMI. In relation to the differences between the Roux-en-Y gastric bypass and the sleeve gastrectomy, there's been a lot of discussions in relation to the effectiveness on the long term. In the STAMPEDE study, there was a favor of the gastric bypass treated patients over the sleeve gastrectomy treated patients. This is a recent meta-analysis looking at remission rates between Roux-en-Y gastric bypass and sleeve gastrectomy on remission of type 2 diabetes after 2 to 5 years. And I must also say that this study is in contrast to other studies. This study, in fact, finds no difference between Roux-en-Y gastric bypass or sleeve gastrectomy in relation to remission of type 2 diabetes. Other studies find that when over time the Roux-en-Y gastric bypass is favored in relation to remission of type 2 diabetes. But the gastric bypass and the sleeve gastrectomy, that's another way of looking at caloric restriction or looking at dietary restriction in relation to treatment of type 2 diabetes. So I'm going to wrap up with this nice picture. You can look at caloric restriction in two ways. You can either do a total diet replacement, or you can do a partial diet replacement therapy. And that is very robust in reducing type 2 diabetes if you have a short diabetes duration and if you are not receiving insulin. However, when you receive insulin, it is also possible to perform dietary interventions with, for example, total dietary replacement. And when you do so, you'll also obtain a body weight reduction and remission of type 2 diabetes, of course, not as robust as if you are not receiving insulin. But the upside is that when doing the dietary or caloric restriction or intervention, you'll reduce the amount of insulin needed and perhaps even be able to get off insulin treatment. The last point, that's the caloric restriction or the dietary restriction in relation to bariatric surgery. It is very important that bariatric surgery is considered as a caloric restriction treatment, since the surgery per se does not induce remission of type 2 diabetes only in the short run. In the long run, it's the dietary restriction and the dietary intervention that is going to be the long-term holder of type 2 diabetes remission. And with these words, I will thank you for your attention, and I'm very pleased to take questions.
Okay, so I was just wondering, when you looked at the Scottish study, the direct study, and you see and you divide the participants into how much weight they lost, you can see that the ones that lost more than 15 kilo,
yes,
they have a diabetes remission rate of about 70 to 80%.
Yes.
And in the big register-based study that we did, that's the same percentage of remission you get after 1 year after bariatric surgery.
Yes.
So that seems kind of wild, because they only lose about 15 kilo, and the ones that get surgery loses maybe like 50 or 60 kilos.
Yeah, but I think that the difference is that I mean to obtain or to have that kind of weight loss, you have to be on a diet in a way so you are still in a negative. And I think that's not the same when you do surgery, because I mean, you have your nadir after 1 year, and then you have a maintenance period. But I mean, the people in the direct study, they have to continuously be on in some kind of a dietary reduced state. So perhaps that's one of the differences. But I mean, it's interesting to follow the DIRECT study for the next year. Interestingly, they had a paper recently in relation to the economical consequences of doing this intervention, and it seems quite positive.
Okay. Matthias has a great follow-up question. He says, if remission is a clinical relevant endpoint, why is it so important?
I mean, you can discuss if that's an important endpoint. I mean, it is for the people entering the study. For a lot of people, they think that remission of their diabetes is, I mean, it's very, very important. And clinically, it's also relevant because, I mean, if you have normal glycemia or you have a controlled glycemia, then your risk of having complications in relation to your diabetes reduces significantly. So it is a clinical relevant point. But you can argue if that should be remission of type 2 diabetes or it should be normal glycemia. That, I mean, that's another discussion.
Okay. Mia has also had posted a great question. She says that in their group they're wondering if there's any adverse effect or any side effects to only consuming 800 calories a day. It's quite low for a long period of 3 months. Yeah,
it is. But I mean, there was no side effects, and I mean, when you're doing the commercial available total diet replacement thing, then it's, I mean, they are balanced in relation to vitamins and minerals. But of course, if you can do a low calorie diet by simply eating 3, 4, 5 eggs a day, and then you run into big problems in relation to general nutritional health. But if you do the commercial available energy replacements, then I mean they are balanced in a way, so you still have a substantial or an adequate mineral and vitamin intake. But it's a good point. It's a very good point, and I mean you have to warn people to do dietary robust or very heavy reduction in their dietary intake by their own. They have to have some kind of counseling.
And Nicole has a kind of follow-up question on that. She writes, do you have any comments on macronutrient distribution for maintaining weight loss and remission? So we talked a bit about micronutrients.
Yeah, but I mean the macronutrients, I mean they differ a bit between the various total diet replacement compounds. But I mean it's they of course reduced fat in a primarily, but I mean the macronutrients are not that important. It's what is important is that you have additional or if you have to have carbohydrates so that you can, for example, be physically active. So you should not shift, for example, to a very low carb diet if you want to do exercise. But you can do this in many ways. But I'll recommend that you use one of the balanced total diet replacement setups.
To all of you asking questions about the gut hormone involvement in bariatric surgery, I think that Christine is going to talk a bit about that later. So I'll save those questions.
But I have a point. In relation to that, because I mean, there was a very elegant study just published in New England Journal recently, where they in fact looked at the insulin sensitivity in dietary manipulation compared to bariatric surgery, and there was a comparable insulin increase in insulin sensitivity. that was related to the amount of weight loss and not to surgery. So I mean that's a very important point, and hopefully Christine is going to talk about that.
Yeah. Then there's some real life questions. Do you think it's realistic to implement a very low calorie diet in an uncontrolled setting when you're not in the direct study, for instance?
Well, I mean, the direct study was performed in general practice, and in fact, the study from Qatar, there was also in what they have some kind of general practice. So I think it's possible, but I mean, you have to have some kind of dietary assistance, a dietitian or a nurse or a doctor interested and knowledgeable in relation to these points, because I mean, you cannot do this on your own. That's an important point. But I mean, it should be feasible, I think.
Okay. So how long follow-up was it on the direct study? That was
2 years.
2 years.
Yeah.
So are they planning 5 and 10 years follow-up?
They're planning, but I mean, the number of participants in each arm is approximately 150. So there is also a problem in relation to a robustness of the number of participants.
Mm-hmm. Then Sasha asked, or she says, thank you for a nice talk. And they discussed the sleeve gastrectomy versus the Roux-en-Y gastric bypass. You showed that BMI was lower after 16 months when doing the Roux-en-Y gastric bypass. So how do clinicians choose between the surgery types?
Well, I mean, in our clinic, we see that the patient, if the patient, for example, has sleep apnea or type 2 diabetes, I will try to talk them into having a gastric bypass surgery, because we know it seems as if the documentation is better for gastric bypass in relation to diabetes remission and also improvement in sleep apnea. So there is a clinical point here, and that's interesting, because I mean the studies they're coming in right now, so the 5 years and 6 year studies, but we need, of course, more studies to be more on firm ground in relation to our recommendations.
Yeah. Any more questions from anyone? I think. Please write your name if you want to ask Jens a question. We have the time for it. There's a new message. I'll check. Sebastian. Yeah, can you unmute Sebastian? Yeah. There he is.
Thank you. Hi, Jens.
Hi, Sebastian.
Our group had 2 different questions. So first of all, I think that everybody's looking for a pill or a surgery that gives you a beach-ready, bikini-ready body. But what is a true goal of weight management and maximizing the metabolic effects? That's the first question. And the second question is, what is your take on time-restricted feeding, intermittent fasting in patients with type 2 diabetes? Thank you.
Well, thank you, Sebastian. I'll take the first question. I mean, in our clinic, and I mean generally, when you do bariatric surgery, you have people with a BMI above 35. So I mean, the majority of these people, they only reach, for example, BMI of 30. So I mean, they're still per definition obese, and I mean, so when I meet the people, I usually talk to them. What is a realistic body weight reduction? And for a Roux-en-Y gastric bypass, that's approximately 30%. But that's also, I can tell them that if they do this kind of surgery, they'll have the 30% reduction on average over the next 25 years. So that's a very good talking point when you start talking to these people, because they've been used to the body weight simply increasing all their life. So for example, they've used 20 years and the body weight has increased from BMI of 75 up till 40, for example. So when they receive a BMI of 30, it will be like being reborn. The second question in relation to intermittent fasting, I mean, that's a very interesting point, and a research area that's becoming bigger in these years. I think it doesn't matter in what way you do caloric restriction. It's important that you are I mean, that you do an intervention that's that you're able to maintain. So if you're able to, for example, to use some kind of intermittent fasting, 5-2 or whatever you want to do, I mean, the important point is that you have to continue doing it. And that's also the point in the direct study. They had the rescue plans. So if your body weight was increasing, you were offered, for example, a new period of 2 weeks of total diet replacement, or if your body weight was increasing further, you could have, for example, orlistat. You could also use some kind of some of the medications that are available right now, for example, Saxenda, the GLP-1 based treatment to maintain your body weight. But the important point is you have to engage in some kind of dietary intervention that you're able to continue to do. Is that an answer?
Yes, thanks. It's a great answer. If I'm allowed some time, I have another follow-up question for the first
short
part.
one.
Short one, yeah. So you said that most get a BMI about 30. So a reduction in 5 BMI points. Do you think we need to get them down to 25 to get to maximize the metabolic effect, or do we just need to get them down to 37 or 27 or so?
I mean, the reduction is not 5 BMI points. I mean, it's the average reduction. I think the average reduction is about 10 BMI points or something like that. But in relation to getting them down to 25, the important point is in fact that they are in some kind of negative energy balance. So if you reduce their BMI to, for example, we have people who have a BMI of 50 or even 60. So if they reduce their BMI down to 45, but they're in a negative energy balance, they can still obtain type 2 remission of their type 2 diabetes. So the point is that you have to be on a negative energy balance. And that's also the point in relation to your previous question concerning the intermittent fasting. When you do intermittent fasting, you are on a negative energy balance, and you'll have effects. It'll have effects on your glycemic control or even remission of type 2 diabetes.